صباح الخير جميعا. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you so much for the organizing and scientific committee for inviting me to attend. This is really amazing scientific gathering that it's been there for 18 years and it's real pleasure. It's the place where we meet and exchange ideas and information. Actually, the topic that I was assigned to give is advances in sepsis. But under that, there were certain questions that I was requested to answer. And I'll tell you what those questions when you see the outline. They didn't ask about the burden. The sepsis, probably all of us we know or we don't know. What's new in sepsis? Okay. Update and controversy in sepsis management. Time to antibiotic. Reality versus fiction. ASP, antimicrobial stewardship in ICU, does it work? You know that when we talk, is there any intensivist here? No, good. So we can talk about them. So, and then we'll summarize it. I'll ask you a couple of questions. Who can define sepsis? Anyone? No? Yes? We'll see. And time to antibiotic. How soon you should give the antibiotic? 1 hour, 3 hours, 6 hours. You heard about 6-hour bundle, and we heard about 3 hours bundle, and even 1 hour bundle, right? Does it work? Anyone knows if it works? We'll see. Okay, so this is because it's, it's a meet the professor session. I'll put some controversy that we'll have to discuss, and please take it, think about it, all what I'm going to discuss today, see what we are applying. Are we doing good for our patient or not? And how we can get better. And I'll talk from quality perspective. So in general, this is what we teach, everyone. And we know that's for a fact. Sepsis, a lot. The estimation 2017 or 16 is around 49 million people. 17 million of them die. It's the #1 cause in US hospitalization. Believe me, there was an assessment, even the GCC country. There is a website study done by University of Washington, modeling for AMR. Go and check what's about our countries because they extract data from different sources. And really, like in Bahrain, it's #1, #3, third killing in the country. So it's really high up there. Mortality rate is high. And this is what we've been taught. And we are teaching our students. Each hour delay, there's probably 7% risk of increased mortality. Sepsis, when time matter. But the problem is that how much we know. How much we know about sepsis really when we talk about it. It's like an iceberg, and believe me, think about this iceberg till the end of the presentation. We know people die, we know people infected, but how much is awareness within the healthcare worker to recognize early sepsis? It's not good, not good. Even the people who are in the hospital, we get consultation as ID when it's late, septic shock in ICU, and it's really probably, we cannot do much. Again, there were a lot of concentration about the public awareness because a lot happened for community-acquired infection that happened outside the hospital. You don't want the patient to reach in septic shock. You want to do something earlier. When we talk about the cost, it's really hard. Cost is hard for anything. If you want to check anything, for example, any disease, and you want to estimate the burden and get the cost, it's hard. When they try, this is one of these systemic review that has been done, and they try to see how much really cost the countries. But if you see across the board, it varies. And you know why it varies? Probably if you calculate it per patient, it will be the same. But you know what's the main reason it varies? How they calculate it. How did you get the cost? Is it the cost of the treatment? Is it the ICU? Is it the physician? Is the other? It's really difficult to extract from electronic medical record. I'm not talking about manual, even electronic. And the problem is that we all agree, despite it varies, sepsis is very common. One of the things that we say about, infectious disease, that it will be the #1 cause of death by 2050. Believe me, we are there. We are there. So it's deadly, morbid, and it's not like deadly. And there is, data that I show a couple of them. Patient get infected, get sepsis. They may die early on a spot. They may die within 1 month, which is the 30-day mortality, and may die even in 1 year because they have an increased risk of dying even after they recover from sepsis. And sepsis is expensive. As I said, it's #1 or 2 or 3 in most of the countries, so it's costing a lot. What's pertinent to our region, and this is the problem, really the problem. This is from actually WHO, which should actually have the data from all the regions. They were trying to estimate how much sepsis actually affecting and the burden and mortality and all of what we think. If you see, as we said, 49 million, this in 2017, most of those sepsis actually came after something else, after injury, after admission for non-communicable. For example, admitted for MI or anything, and they get hospital-acquired infection. The mortality with hospital-acquired infection sepsis is more than if it's a community. And most of the top 2 reasons for this sepsis is 2. Lower respiratory tract infection and diarrhea. Diarrhea is amazing because you know that if you, I can't say that I saw a lot, but there are amazing cases that admitted just gastroenteritis and septic shock and they die. I think we are underestimating diarrhea. WHO could get estimation from all the regions of WHO except our region, EMRO. They couldn't say how many people die of sepsis or septic shock because we don't have data. We don't have data. Actually, one of the major work, I work a lot with WHO on different tasks and teams. The most important obstacle for us, barriers, even when we try to estimate critical pathogens, put a priority for the whole world, is that we are stuck with data from the EMRO region. We don't have enough. But if you see the mortality, even the top countries, it ranges from 30 to 70% mortality, especially if the patient is in ICU. But this is what's shocking. Mortality by infection, injury, or non-communicable diseases by age, okay? We would thought that the non-communicable diseases, hypertension, ischemic heart disease, heart failure will be the #1 cause of geriatric population. And the problem, no, it's get actually better as they get older. The only one thing that increases as we get older is the infection, mortality related to infection. And this is the group of patients that get admitted. And really, you cannot really deal with them easily. Maybe the other hat I have, I'm a geriatrician plus medicine and infectious disease. So geriatric elderly population, they cannot handle infection. Their immune system is really, after being mature, it returned to be immature. So there is a kind of inflamed aging. So mortality for hospital-acquired infection, sepsis, is around 25%. But believe me, it varies from hospital to hospital. And I show you some of the countries and the region reaching even 70%. Most probably in the ICU, higher median length of stay, up to 1/3 caused by drug-resistant, the MDRO that we hate all of them because this is what we see all the time. Now, I'll present a couple of what we think new and we believe in them because that's what we do. Okay, we see evidence, we see data, and then we translate it to our practice because at the end, we want to save lives. So this is from Surviving Sepsis Campaign. It was, initially 2016, revised again. But the most important message that we got, that all of the studies regarding if you got pneumonia, bacteremia, intra-abdominal, and urinary tract infection, shorter is better. And there are a lot of studies to say how much shorter you should go, probably not less. So if we said 5 days minimum for pneumonia, it's 5 days. You can go 3 days, but they go with 5 days. So there is enough study to say shorter is better. And the other thing, and this is really important, I hope that concentrate in this slide. Antibiotic time, because we all, push, please start. And, when we go as ID, we teach our students and the residents, start, antibiotic as SAP as soon as you can. But the most important thing to differentiate is the patient in shock or there is no shock. And this is when I asked at the beginning, do you know what's sepsis? What do you know about severe sepsis or septic shock? Because if if there is shock, you have to start as SAP. When you see the patient in shock and that's most likely infection, just start. But if you think the patient has probably sepsis, he's not in shock, okay? Maybe infection, you have time to investigate. And I'll show you the data that tell us you have time. These are the guidelines, you can go, we will not go about it. Number 2 points. As I said, the sepsis is a continuum of care. Actually, we see them only in the ICU, like 5th in the cycle. A lot of initiative, and I'm talking here quality of service, should have been started before the patient hit the hospital. When it's too late, it's too late. So there is a lot about recognizing it. So you do severity assessment and a pre-hospital early therapy. There are a lot of studies out there. You can just go emergency room, ambulance services. If they go home, and they want to pick anybody, what they do on a spot makes a big difference in the mortality. So you have to educate more people before even the patient reach your hospital. And then you have to go for secondary prevention. As we said, people die even up to 1 year higher risk after sepsis. These are the points that was addressed in the article. You can go and look at them. We'll go into the details. So what's changed? Number 3, what changed the advance in management of sepsis? Really, there are a lot of future direction. You will start, I'm sure you heard about a lot of things, nanotechnology, AI, mechanical learning, a lot, signaling pathways, a lot there. What we do as physicians, what should matter, should know about them, but not in details because probably I cannot use them, but it can be because of this. And this is very important graph to understand sepsis. Again, back to the question, if you can define sepsis. Now, the most accurate, actually, probably definition of sepsis is like, it's a systemic, okay, where there's inflammatory and immunological disturbance in the body. So you have two things. So once patient hit with, there's hemostasis, we are living really okay, and you hit by infection, either people die early because overwhelming inflammation. That's when it hits. They come within 2 hours, 3 hours of the infection with septic shock. If they recover, good. They still can die because there is an persistent immunosuppression and even long-term death, as I said, up to 3 years. They have higher risk of dying because of the damage happened from that sepsis. What about our patient who get admitted every one month or 2 months with sepsis? What do you think? And please, if you just try to remember a couple of cases or 3, I'm sure you see the same case scenario, especially in elderly population. Once they start get admitted for sepsis, you'll see them again and again and again, mortality. This is how it starts, and this is how it continues. And there is really not much we can do as physicians. What that help is going for the future. They look for it because it's inflammation and it's immunological response, and our immune system is not the same. We are different. If I take this one medication, I will not be responding like you. It's different. So what they try to do, and this is when we said about patient-centered care or precision medicine. And this is all about, believe me, started United States, they are utilizing it. They go by the genome, they go by the immune system, and they tell you even what's the best antibiotic you can use. So patients with sepsis, they have some clinical trait, how they respond to the sepsis, and they give them certain phenotype. They try to do this to have a prediction modality that can help us in early prediction of septic and septic shock. It's working. Some studies say it works, some of them say, but in general, it's still doubtful because of the complexity of sepsis. Again, paradigm shift, nanotechnology. And as I said, it's a lot from the infection, pathogen, and there are 2 words here, PMP and DMP, which is either because the organism is in our body and the release of particle from the organism, or because of our immune system and the circulation, all those cytokines release in the body and causing more damage. So all of this really affecting the immune system and make us immunosuppressed after the infection. This is where the nanotechnology goes. There is a lot. Nanosensor, I'll not talk, I'm sure we have microbiologists here that can help. A lot of advances there to predict early. We can check CRP, procalcitonin, and I don't know what, but there are to detect earlier, and a lot has been done by the next generation sequencing. We were happy before to get the cultures within 48 hours, 72 hours. Now we're talking about 6 to 12 hours to get the result. We needed to tailor the antibiotic prescription, so we are heading there. So what's sepsis really? And I said, it's very difficult. Actually, the word sepsis has been there more than 2,000 years, from the Greek rot. But still, it's very complex because the pathophysiology is very complex and really hits a lot that you have to do the patient, get their immunological, not only inflammatory biomarker. This is why biomarker by itself does not help. And I'll show you what's happening with the biomarker, especially for septic shock. And then do some modeling because AI is coming, and then to forecast to see who is going probably to progress and die. It's working in some places, but probably still we are not there, but it's coming. The other part of nanotechnology, not only for diagnostic, even for treatment. And you see, we are using different modalities, lipid-based, polymeric, or inorganic, to create the best medication, because those antibiotic, antifungal, antiviral, we want them to reach where we want them to reach, to work better, actually. And there is some advantage and disadvantage. Another thing, as we said, pathways of sepsis, very complex. This is it. It's hard to tackle all. Okay, but okay, there is, you can, hit the neutrophils, endothelial barrier, because we know that it gets disturbed in the sepsis, nanoparticle for diagnosis and management, and then target the damage release particle or the pathogen release particle. Please, if you have time, look into this article. Go and read what's happening. It's really a lot out there. We're still not using them, and these are some examples of how to tackle agents and signaling pathway. Example, what's there out in the market. You don't have to look at them, but believe me, a lot is going on to know if we are doing a great job or still we are not doing it. Sepsis. AI, a lot, everybody's talking about AI. This is the new fashion we have, so we have to talk about it. Really, is big data, this will help us to predict sepsis and manage sepsis. This is one of the studies that's shown earlier in 2018, they revised, it was, computerized system. They revised 17,000 patients, validated. The machine decided for us if, we have to give antibiotic and what antibiotic. And believe it, outcome was much better when the treatment was given by physician and matched with the AI. Are they better than us, the AI? I don't think so. But the problem, when we go and assess the patient, we don't take everything in consideration. And still AI will solve a problem. It will not replace us. It will not replace us. And this is very important because it should be a supervised AI or mechanical learning to be able. And this is another one, machine learning, and how we can do it. The outcome, they try to revise all the articles available in AI and sepsis. Again, the problem is they are not unified, not in the definition of sepsis, not in the biomarker they use, not in the vital sign use. So there it was hard to give a conclusion. Some of them studies said it works, some of them doesn't work. So still we don't have conclusion that AI will replace us. So be happy, still they need us actually to make some decisions. The point which is important, and I think for us all, we know the first rule we know in medicine and being a physician is do no harm, is quality of service. So now everybody's talking about performance indicator, KPI. It's very interesting because when you see the pathophysiology of the disease and the pathway that the patient will take from reaching the emergency room till ICU or mortality, it's very complex. A lot of people are involved. Medical records is not easy to extract the data. So I'll go to this article. Do you know all of you about SIP1? 6 hours, 3 hours? Okay, it came in the picture, okay, and this is good. This is good because the Center of Medicare, Medicaid, United States, they decided sepsis is a big burden. We have to make it a quality initiative and we have to do bundles. Everybody loves bundles because it works. We do checklists, we do it. And they ask the hospital to be compliant and they do it. And the hospital who does better, they will get extra payment as Medicare, Medicaid for the patient. So all the hospitals were really happy because sepsis is a priority and it was one of the top topics in the health system in the United States and Europe at that time. So it was started. The IDSA, they created a team, they revised those suggestions. Does it really work, 3 hours and 6 hours? Do we have data tell us that we save the patient and we decrease the mortality? We'll have to see. So they want to see if you measure anything, it should be evidence-based. Discriminate between severe sepsis and septic shock, and I'll tell you why. Simplify time zero. You remember we said 3 hours, 6 hours from time zero, right? What's time zero? When the patient comes to emergency, when we open the file, when seen by the ER, we refer to the internist, when we started the antibiotic, who knows? And all of those data that were extracted is retrospective analysis of electronic medical record. So we'll tell you why the IDSA team didn't like it. They say this is a good initiative, but we'll have to do a lot as a society. Bundle should be revised, and it should be only for septic shock. Minimize overuse. There is a lot of overuse because you suspect early, you think it's better, 3 hours, 6 hours, you start early. We said start antibiotic early to save life. And don't do something that does not make a difference. You know the idea of lactate measurement? Lactate, lactate, lactate. It's, evidence, there is no evidence that helps. Making report electronically so we extract more of KPI that help us. So they give several recommendations. I'll concentrate only a couple of them. First of all, SIRS. They say just eliminate it. Actually, SIRS is one of the major reasons for us overprescribing antibiotic because of the differential diagnosis for a lot of non-infectious diseases. So they want to eliminate it. Done. Septic shock, to concentrate on it and apply the bundle on septic shock. This is very important. Time zero should be identified. And you know what? The other thing, like vasopressor, there are a lot of confusion about vasopressor. There are a lot of still confusion and controversy in the amount of fluids. Give more or less, okay? Because when you give more, they say you overload the patient, you give less, it's under. So a lot. They said we leave it to the critical care teams to decide about them. So this is very important. And really, they said broad spectrum within 1 hour from zero time for septic shock. This is no question. Any patient admitted as shock and you think it's infection, start antibiotic. None is against this. But what's the real world evidence about this SIP1, 3 and 6 hours? I'll give you a couple. Really major data is out there. And that's why the IDSA came with the recommendation. Believe me, we're still applying it in the hospital, right? So this is one, treatment pattern and clinical outcome after introduction of the SIP1. This is 54,000 patients. And I'm telling you, see the numbers, a lot analyzed. From this hospital, it was 11 hospitals, and they used SOFA defined septic between 2013 and 17. And when they hit with the SIP1 introduction, they want them to do it. What they found, increase in lactate. Okay, they testing, everybody do lactate because they want to know. Broad spectrum increased, and the amount of fluid we give to the patient increased, but mortality didn't change. Another study. This is another one which is bigger. It's almost 120,000 patients admitted to 114 hospital. They extracted the data, blood culture there, 2 SIRS criteria, acute organ dysfunction. So we probably know what's happening. The same result. Lactate, everybody's measuring, antibiotic, anti-MRSA, and antibiotic, anti-pseudomonal more. Mortality didn't change. Another one. This is another one. They look what's happened with the SIP1. All others admitted to 26 hospitals, 700,000 patient data analyzed. This is not easy. We're not talking about 1,500. And then what they found, 10% increase in antibiotic utilization. But the problem, no change in mortality. What we are doing? That's the question. Is it the quality of care we are looking for? Probably not. Probably not. So we'll have to have an answer, I think. And this is another one which also look, and this is here where you have patient admitted and the same results. See how much increase in antibiotics. So where is the stewardship? Where the idea we are talking about? And this is one of the things the IDSA, they were criticizing. Within all of this to start antibiotic, you didn't really say, order antibiotic, because we have a major problem in our hospitals. I can order antibiotic, but I don't know when they give it. Maybe 1 hour, 3 hours. It doesn't mean I order it within 1 hour, he will receive it or she will receive it in 1 hour. So they emphasize this point. They want to know what's happening. And doses is right, coverage is right, nothing about it. It's purely going in the direction that we don't. It's outcome-based KPI. So all of them prove that there is more lactate measuring, more fluid, more broad spectrum, and no change in mortality. But they again ask one question. Were these hospitals compliant with the bundles? Because we know if you have more compliant with the bundles, maybe they were not doing it right. Probably will have a better outcome and we can decrease the mortality. And they say, we'll revise. So they look for compliant hospital and none. And there was little bit decrease in length of stay, but not much in mortality. It comes back to the same point I mentioned earlier. Documentation, co-founders. Presenting symptoms. Some people present vague symptoms. They're not clearly septic shock, but they are septic shock or they progress. It was hard because if you have patient who's very clearly septic shock, they will be more compliant with the bundles. If it is vague symptoms, I will not do the bandage. I wait till the symptoms show up. Then location of sepsis. Some people, because they have community-acquired infection, they come in septic shock too late to apply those bandages. Hospital, actually, they really have it better. And whether it was septic shock or only severe sepsis, actually, you will see. When they try to compare apple to apple, when it was septic shock, mortality rate with compliant or non-compliant actually didn't make a difference. And that's a problem. So it's highly confounded, and they are asking to revise all and retire the SIP-1 bandage to have a better outcome. So it's really, we have to leave it to the physician. As I said, they still need us because we have to decide, we have to tailor the management to the kind of patient we are seeing in emergency, in ICU, or on the floor. You have to tailor it, and it's a full continuum, and this is very important. Plus, they suggested a lot can be done as KPI, and it has to be improved with the SIP-1. We'll not go into details, but I think it's nice to go over the article. You have, all of them, the guidelines, the bandages, the revision, and the recommendation. So I'll go to this. So I have 2 points to discuss, time and ASP in the ICU. And then I'll open the floor for question. If you don't ask, probably I will ask. Okay, so we'll see how we can get more information. So is every minute really matter? You remember we said start, and still we are teaching our medical students, if there is any students, start the ASAP when you see patients, severe sepsis, they will die, don't just like, what? And we hear that, and you see the graph that we all, and the studies earlier, each hour will delay and increase mortality by 7%. Yeah, it's still valid, but it has specification. So some of the earlier studies that was there in 2017 that showed really time, each hour interval will increase the odds ratio by around 1% if you delay the antibiotic, but it's really more complex. I'm not a mechanic, so I don't know nothing, so this is too much, and sometimes even medicine. But the problem is that when they decide about this 1 hour, they combine two topics, the severe sepsis and septic shock. They didn't separate them. The other part, we assume, and I hope that you were like me, I thought that it's linear, infection, sepsis, severe sepsis, septic shock. I thought it's like this, and if I start the antibiotic here, I probably drop it. That's in my mind probably earlier. But it's not linear. And this all observational data, as I said, most of the study go retrospectively, pull data from the medical record. The medical record actually depends on our junior people because they do the work, we just supervise and give advice, and what they document. So the documentation is crucial to get those data. So this is like, if it's matter and really delay in antibiotic from, this is a New York study in 2017, only people on vasopressor, it makes a difference, which means septic shock. Again, only patient with septic shock, the delay will make a big difference. So sepsis is not linear, but you can do something. If the patient has septic shock and you started the antibiotic before really they go, which is like within 60 minutes, and this is the 1 hour we are talking about, you can change it and you can slow the care. In not septic shock, believe me, it's not linear, it's up and then get better, they get better, because most of these cases actually are non-infectious by data driven. So this is like the time when it's no fever and normal blood pressure, and they have the SIRS that we talk about it, probably you have 4 hours window period to investigate and look and see. If the patient has hypotension but no fever, you have probably 3-6 hours. Fever, normal blood pressure, 2.9. But really, when fever and hypotension, this is when you suspect septic shock. That's where time really matters. This is where you have to do it ASAP. And when you put those co-founders, like this study which was published in 2023, they tried to analyze, believe me, till today, we try to understand sepsis and try to find a way to decrease the mortality. And I said the mortality is increasing because the number of immunocompromised patients we have in the world, immunosuppressed, transplant, biological agents, everything, they are more. We are getting more sepsis. When they put the other risk adjustment, you will see that if they have septic shock, those time to antibiotic really matters. And again, and I said there are a lot of investigation and really initiative to give antibiotic earlier. in the ambulance or in the emergency room, and they were randomized. If you give early antibiotic to the usual care, probably does not make a difference because most of them were without shock. So it will make a difference if it was shock, but if it's not shock, probably it will not make a big difference. So the problem, we are over prescribing antibiotic. And these are the other differential diagnoses, and this is the problem with the systemic inflammatory response, SIRS. This is why the IDSA and probably other society, they don't like it because these all diagnoses present like SIRS. And excess antibiotics is harmful. Look at this. This is amazing. This was published in 2020. If you give 2 neuroantibiotic, yes, mortality still will be high, but will not have side effects. If you give 2 more, patients still will die, but they will have other side effects. So what to do? That's what we think. This is where we have to make the right decision for the patient. Patient ultimately is dying if you don't give the right antibiotic, but we don't want to give more because it's harmful. And they can do a lot of damage. Tailor, this is, I think, the most important message we'll get from this presentation. Tailor the urgency of antibiotic to the severity of illness and likelihood of infection. And love this graph because this is what's in our mind. This is how we calculate it. Is there infection? Is it infection we are dealing or none? That's one. The other, did they reach septic shock or only in severe sepsis or possible? If you go to the green, highly suspicious, it's infection, and the patient is septic, just go ahead, give the antibiotic, nobody will question you. But if it's lower there and it's still doubt, I don't know what's happening, you have time to investigate. You have time to do it right and not to give more antibiotic. Okay, antibiotic stewardship in ICU. Hopefully no intensivists yet, right? Yeah, good, okay. Because our intensivists really hate us when we go and we try to restrict antibiotic. The question that I want to ask, the stewardship, can we de-escalate in ICU? Does it work or doesn't work? So I'll present like around 4 articles, but really very important. If you work in ICU or you're doing stewardship, please look at this article. Very nicely, well written. The first one is principle, and I think that was in 2017, about principle and practice of antibiotic stewardship in ICU. And they look for, the complication of antibiotic, length of stay easy, cost easy, treatment duration. When we do stewardship, please pick the things that you can measure, because there are a lot of things you cannot measure. So I think in this article, they put what we can look for, our target outcome, and they put all the elements as any stewardship program that should be in the ICU, and you will be able to do it. This is a nice article. It was published in 2019. This is by Bassetti, if you know him, well known in the MDRO world and antibiotic consumption. He loves algorithm. If you know Bassetti, in all his articles, probably there's something algorithm and what to do. Beautiful one. So what they saw as the role of stewardship program in ICU is this. You suspect infection in critically ill patient. We are talking about ICU people, sick people, shock, okay? You go there, obtain whatever you want, culture, biomarker, whatever you like to obtain, just obtain it. Start the empiric treatment based on your antibiogram and epidemiology, monitor the response, get the identification of your organism. If you get it, tailor it, good. If you didn't get it, or you didn't get anything positive, and we saw those cases that, we think it's septic, patient's getting better, but no cultures. So either you consider discontinuation because you don't have evidence that's bacterial, or if you still think it's bacteria, you have to reculture and order and to make sure that's been done. Good, this is stewardship. But then, this is the other article. I would love that. If you want to read this one, okay? This came in 2023. They talk only, about antimicrobial de-escalation in the ICU. And this is with the European Society of Intensive Care Unit with the CMEDS, group for septic and critically patient. It's beautifully well written. You remember that algorithm, right? Now, this is almost the same with one thing very important, is that you see the patient evaluate, source control they added, which is very important. And even with the SIP1, 3 hours, 6 hours, nobody mentioned that source control, which is very major in septic. You have to control the source, otherwise your antibiotic will not even work. And then you start the antibiotic based on your assumption, reevaluate, it's not only de-escalation. We sometimes escalate, right? You go to the ICU and you add more. It's not every time we stop or change. Sometimes we add because it's undertreated. So they added part or agree with the team, continue the same. So this is like step forward, but they put recommendation for certain question, very critical question. And I'll just go over them quickly, but really I recommend you read the article. It's a beautiful article. First, about definition. They define de-escalation, okay? It's not stopping, it's not discontinuation, it's de-escalation, which means they want you to do either replacing broad to narrower, or not to have double coverage, or if the culture come and you can remove one and they define it, and is not discontinuation, is not de-escalation. Discontinuation is discontinuation. De-escalation, you change it, you make it better, you adjust it. This is one. Any score to help? There are a lot of studies that put pathway, score, sepsis, prediction. They say there is nothing yet. Still, they need us to be there to assess. Till a good score comes in the market, probably we'll use it. Then, antimicrobial stewardship program. What they recommend? De-escalation will affect the mortality? No, it's safe in the ICU. So you can do de-escalation in the ICU, and we know we've been doing it for a while. And then the effect of de-escalation and the total duration, what they found that they prove by evidence, and look at the article, when we de-escalate, we give sometimes oral, and instead like 5-7 days of IV, we change it to oral of 10 days, 14 days. So there is a kind of change in the duration of antibiotic, probably more in some cases. And then what's the effect of de-escalation and resistant? Actually, they couldn't say because there is no enough data. We thought, or we know, that if we decrease the antibiotic exposure, we'll be able to reverse this MDRO. This is a lot, but very important. I will not read them, but I'll tell you the main recommendation from it. Stewardship in ICU works for antibiotic, for antifungal. It works, there is evidence. And then it will not affect your mortality. Actually, it's safe and you can use it. The other two things that's still not there, the use of biomarkers. Do you know how much we talk and we give lectures about biomarkers and sepsis and procalcitonin and I don't know? They didn't find any evidence to prove that procalcitonin can help in de-escalation. They say it can decrease, only the evidence is really, it can decrease probably kind of the duration, but not the type of antibiotic as per the definition. Broad spectrum from narrow, it does not change. So this is where it's under, they couldn't make any recommendation, and therapeutic drug monitoring also they couldn't put any recommendation. So basically this is another, just please rethink about our biomarkers. There is a use for, I'm not saying you cannot, you use them for certain things. For me, procalcitonin is a must in any patient because I use it, I utilize it with certain algorithm, but really it has different sensitivity and specificity, especially with the patient in the ICU because they are completely different. Their metabolic system and pharmacodynamic is completely different. So think about it. So in intensive, this is the last one updated and it's just published. We have co-founders and we have to arrest those MDRO. We know that the patient, and this is what we hear from our colleague in the intensive care unit, patient are sick, this is not patient on the floor. We know the patient is patient sick and we know. So we have to make in consideration how we choose our initial antibiotic. And this is what they recommend if you want to do ASP. This is beautiful about this article. What do you do before treatment? During treatment, pharmacodynamic and source control, daily assessment, discontinue if you want. After treatment, use automatic early warning sign to see if there is a relapse. But I like the last one, cooperate and communicate because it's under the ICU and we have to work with them. So this is very important and they have different suggestions. And as I said, you can do stewardship program in ICU, yes, but really you have to be careful what you are measuring. Most of the studies decrease the consumption. If you see it's mainly consumption, cost, and that's majorly, it's consumption and cost and duration, length of stay. But mortality, morbidity, long-term, it's hard to calculate. I wish we have this data, but it's hard to calculate, so important to look at it. So before I conclude, for the young, physician out there, researcher, these are priority research question that, all of us dream of having an answer for them. Some of them clinical, some of them basic science. But I think if you look at the question, you will know how much we still don't know about sepsis, okay? So what's the best strategy for screening and identification of sepsis, early recognition? Predictive modality, this is where AI should come in the picture. Organ dysfunction, what's caused it, how define it, how to detect it early, and fluid resuscitation. When, how, believe me, it's still out there. What's the best vasopressor? And personalized precision medicine. You will hear more about this, it's coming, because you know that a lot of countries, even the region, we are with the genome, and countries level, they are analyzing their genome, and big budget are being assigned for it to reach that level of precision medicine. And we know it's very important, and we're really looking forward to see if it really helps us in saving patients. So we talk about surviving campaign, we look for the guidelines, we question some of it, but still we know that the patient should be number one. Each patient is different. With sepsis, they are not the same. I know in a lot of things it's not the same. We say one size does not fit all, especially with septic shock. You have to go and see it, and still they need us. And probably even like infectious disease, you've been there for enough time. For the junior, seeing the patient yourself and looking at the file yourself and is different than from hearing it from somebody else. Completely different. Patients sick in ICU, go as SAB, do full evaluation. I know we are moving to AI and I don't know what, but still that cannot be replaced. So make sure you do your work right. Data, most of it for bundles, for time to give antibiotic, for working mainly in septic shock, okay? And then the urgency of antibiotic should be tailored to the severity of illness and the certainty of infection. A lot said to us and give us that ASB, antibiotic stewardship, works, but we have to do it very well. So you remember the iceberg I presented earlier? We know how many people die, how many get infected, but we don't know how much misdiagnosed, underdiagnosed, or maybe overdiagnosed with sepsis. But here is the problem. What we really know, what some of us might know, what you really should know to be able to perform better. And I don't know, something that probably we don't know what is it, we don't know what we are looking, but we are there only, what we know. I think we have to do more. And within the sepsis, there is actually more. And this is just for the fun. Known the unknown. The only one thing we know is known the knowns, the very common knowns. And even those, as I show in the presentation, questionable. If you are really a data-driven person, you have to look. And this is, I think, the IDCA task force, they made a really great impact. So when we give bundles, question them, do studies, see if they work or they don't work, because really, even we are working towards algorithm, precision medicine as we move, because the old is intuition, sign and symptoms, and now we are evidence-based and clinical trial, and they are going precision. But when from the presentation, what I show you is still you need those signs and symptoms, and you need your personal judgment to be able to use algorithm and even AI. So the human is still needed to make a big difference. At the center of all of the care we give, especially sepsis and septic shock, quality of care is number one. And thank you so much for listening. Thank you.